the role of transplant, we're usually talking about allogeneic transplant, although sometimes autologous transplant can be used in the setting of Philadelphia chromosome positive ALL, although as I discussed earlier, the efficacy of the current treatments, even without transplant, is getting so high that transplant can be deferred in most patients. So the decision about who goes to allogeneic transplant, and again, it kind of fits into very intensive conventional chemotherapy, that both of those therapies have high toxicity rates, high death from treatment-related death or non-relapse mortality associated with them. But there are patients who definitely will benefit from an allogeneic bone marrow transplant. Currently, some of the best data has come from out of Dr. Bassan's group in Italy, as well as the Graal group in France, basically showing that MRD, or minimal residual disease, at the end of induction, especially at levels over 0.1%, predicts a very poor outcome with chemotherapy alone. Whereas patients who are MRD negative at the end of induction can have a very good outcome, approaching 80% disease-free survival and overall survival if they're MRD negative, versus that drops to about 20% if they're MRD positive. So MRD testing, minimal residual disease testing, is absolutely essential in the care of patients with acute lymphoblastic leukemia, because it really guides the decision to use an allogeneic transplant or not. The Graal group combined data from 2 of their studies where patients who had high-risk disease were allocated to allogeneic transplant. And basically they found in that study is that patients were MRD negative, and it didn't matter whether they got a transplant or not. Their outcomes were basically the same. Their survival was the same. However, if the patient was MRD positive after induction, there was a huge benefit to getting an allogeneic transplant. We're talking about myeloablative allogeneic transplant relative to not getting an allogeneic transplant. So these are never randomized studies, but it was very, very strong data in a large patient population and 2 prospective clinical trials. And so other studies have confirmed or have shown similar things, I should say, that the MRD positive population is really the one that benefits from allogeneic transplant. So my practice is to reserve allogeneic transplant for those patients that aren't able to get to an MRD negative state early in therapy, usually after induction. Some practitioners will also consider allogeneic transplant for patients with high-risk genetic features. Those include patients with hypodiploid karyotype, often associated with p53 mutations, patients with KMT2A translocations, and previously Philadelphia chromosome positive was considered a negative prognostic, although we don't consider that anymore in the age of the modern tyrosine kinase inhibitors. So for the kind of the high risk patients, which all can throw complex cytogenetics in there as well, for the higher risk patients, some transplanters will consider transplant because those patients' outcomes with chemotherapy can be poor. My feeling is that the actual studies have shown that even in high-risk patients who go to, which is the study I quoted before, the high-risk patients may not do as well as the low-risk patients, but if they're MRD negative, there's no established additional benefit from allogeneic transplant if they're able to get MRD negative status. So I base the decision for allogeneic transplant on the clearance of the minimal residual disease. The last category is patients who didn't have minimal residual disease testing done, and that's a very difficult situation because we don't know the best therapy for those patients because we don't know if they were MRD negative. Studies of MRD unknown suggest they do as bad as MRD positive patients. But we don't have a large body of literature to look at to make those decisions. But if MRD is unknown, I definitely discuss with the patient both the risk of their disease risk as well as what the existing literature shows on that. And we make a decision together. Well, we always make a decision together, but it becomes more of a discussion of the patient's values and risks they're willing to take one direction or the other.